Welcome to Biology 2402 Lecture Series, Chapter 23, The Respiratory System. In this chapter, we're going to look at the overall function of how the lungs bring in oxygen, remove carbon dioxide, and play a role in things such as pH control of the blood. Likewise, the respiratory system will play a minor role in the sense that it will deal with the respiratory's defense system. Now, our first slide that we're going to look at is this one, an introduction to the respiratory system. Here we see much of what has been said a moment ago. The main role of the respiratory system is this bottom bullet that says through mechanisms we use oxygen and produce carbon dioxide. So the respiratory system will bring in oxygen, remove carbon dioxide, and it plays a role in things like defense in terms of mucus secretion, protection from germs that get into the respiratory system, things of that sort. So that's what this system is all about. And notice it says cells produce energy. That means that in order for us to be very aerobic, we need to have oxygen brought into our body. Now, anytime I say aerobic, we should be thinking about chapters in 2401 biology that had to do with the system of muscles. Muscles were very aerobic. Cells are what? Very aerobic. Next slide. Again, notice the theme that the author is bringing here too. Again, it is a story of being able to do what? Bring in the oxygen and remove the carbon dioxide. So you're going to see that repeated theme over and over. In this slide it says it is obtained from the air by diffusion across the cell, or in this case the exchange between the lining of the lungs, the alveoli that we'll see later, along with the cells and blood vessels. So there's going to be several relationships here, and each of them, whenever we have the movement of oxygen as a gas, we're going to be moving by way of diffusion. Now, the purpose of the cardiovascular system that we've been harping on for chapters 19, 20, and 21, its job is to be in conjunction with the respiratory system to bring the carbon dioxide to the lungs and take the oxygen from the lungs. So the cardiovascular system actually works that way. That is why when someone does CPR, the whole form or the full form of CPR is cardiopulmonary resuscitation. So when someone does CPR, it's cardiopulmonary because they are related. One other example I'll give is that when you're having surgery done with an open heart surgery kind of thing, they use what's called a heart-lung machine. So these two systems, the cardiovascular system and the respiratory system, are linked that way. Now you're noticing that as we've done chapters 18, 19, 20, 21, and 22 so far, there's a lot of connection between systems. You did not see that in Biology 2401 as much, but you'll definitely see it in Biology 2402. Next slide. Here we have the 5 functions. First, we see the utmost one that I've already talked about, and that is gas exchange between the air and the blood, and between the cells and the blood. And that's what these 2 first ones are going to relate to. The next one protects against respiratory surfaces from the outside environment. This is where that mucus story comes into play. The last 2, producing sound, that's your vocal cords playing a role, so producing sound. And the last one that you saw in Biology 2401 in the nervous system with cranial nerve number 1, olfactory, the sense of smell. So these are your 5 functions of the respiratory system. Again, notice I did not read each one of these line by line. I gave you the main gist of each one of them because it's better to understand what these say than to write them down and keep writing them down, keep writing them down. Okay, next slide. Here's the organization. This slide is very important. Notice the landmark. The landmark is the larynx. Larynx and above is your upper respiratory system. Below the larynx, it's the lower respiratory system. So if you have a sore throat, that would fall under the upper respiratory system. If you have pain in your lungs deep down, then that's your lower respiratory system. So when it comes to infections, as long as the infection stays in the upper respiratory system, you're above the larynx and it's not as bad. Lower respiratory system, you know that you're going to have a deep issue. Next slide. So this slide's important. Next slide. Respiratory tract. Now the respiratory tract actually has two main functions, or two main portions. And I said a moment ago functions because it's the function and the systems, the structure that goes with it. So here's what I'm getting at. Anything that is from terminal bronchioles up, and that's how this translates right here. Anything from the terminal bronchioles upstream is conducting portion. That means their role is only to do what? Conduct air. So terminal bronchioles and up is simply to conduct air. Respiratory bronchioles and down is all respiratory portion because that's where gas exchange will actually begin. So again, let's go back to this slide to refresh ourselves before we move further. It turns out that the structure will play a role in its function. The conducting zone from terminal bronchioles and upward is only conducting the air, moving the air along. Whereas respiratory portion, which is respiratory bronchioles and downstream all the way to the alveoli, they actually play a role in gas exchange. And you'll see that at the very bottom here as well. What are alveoli? They're air-filled pockets. What do? That's where gas exchange will take place. So the alveoli belongs to the respiratory portion, therefore places where gas exchange will occur. Now before I go further to the next slide, you see where it says air-filled pockets. Air-filled pockets is because of surface area. So if someone with emphysema, as we will see later in this chapter, has loss of these air-filled pockets, they'll have less area for gas exchange. So if you're a 4-pack smoker per day and you've got emphysema and you've got issues with your alveoli, it's because you've lost more and more surface area for gas exchange. Next slide. This picture is an important one. It is on page 815. This slide you should know well. Notice we have our frontal sinus, nasal concha. I'm going to give you another name for that in a little while. So nasal concha, the nose, the tongue. Here's that hyoid bone that you learned in 2401, the larynx, which contains what we commonly call the voice box. So the larynx, and your vocal cords are there. Your vocal cords will be in this space right there. Then we have our trachea. Then we have our first branch, which is the bronchus. We have multiple branches, and then finally we have another thing called bronchioles. Now the bronchioles are broken down into two parts, as you saw in the previous slide. We have the terminal bronchioles, and then we have the respiratory bronchioles further down. We have our right lung, and we have our left lung. You can always identify the left lung by this indentation here. Some books call it the cardiac notch, and we'll see that on a later picture. So left lung, right lung, and again the cardiac notch. Next slide. Respiratory epithelium. Again, notice what words keep coming up. Gas exchange. And these walls that we're speaking of for the alveoli are very thin. Why thin? Because remember, diffusion is best for short distances. Look what it says here. Surface area must be very great, about 35 times the surface of the body. So again, we have a lot of, and I'd say in the order of millions just to exaggerate and give you an idea. Our surface area and our number of alveoli in our lungs, we're looking in the millions. Okay? And each alveoli wall must be very thin because of gas exchange, best for diffusion. Next slide. Respiratory mucosa. Now, the moment you say mucosa or mucus, you've already learned that in 2401 what type of tissue produces secretions such as mucus. It would be the epithelial tissue. So we have an epithelial tissue as a deep lining, the lining of the lumen of the respiratory tract. So epithelial. These are often easily replaced and torn, and that's why, just like in your gut, as you'll see in chapter 24, the epithelial lining is easily replaced, high mitotic rate. Below that, we see the areolar layer, and in this case, we commonly call it the lamina propria. You will see that term again even in the digestive chapter of chapter 24. So that when we say lamina propria, we're talking about the connective tissue. So areolar tissue, connective tissue, lamina propria. And again, notice it says here lines the conducting portion. It's only the passageway of air. It's not for gas exchange. Next slide. In this slide, we just see a picture version of the cilia. Now, the cilia is designed to actually move and vibrate upwards. So it moves the mucus and the dirt and debris up towards the nose or up towards the mouth, and you either spit it out or you sneeze it out. So that's the purpose of the sneezing and the coughing out. Next slide. This picture shows you the cilia, as I've mentioned, shows you the mucus and whatever germs or dirt that's trapped in it, and how the cilia's job is to move it upwards towards the pharynx, which is basically the back of your mouth. Towards the pharynx, the back of your mouth. That's an important term because it carries over into the digestive system as well. You see the cilia, you see your epithelial lining. Notice it's columnar. So you see the epithelial lining, you see the thin basement membrane, and of course, as I mentioned before, anytime you see the word lamina propria, we're talking about the connective tissue. This is what's often easily worn out and torn as you age. Okay, next slide. Here's an enlarged view of the same thing. Again, you see these mucus cells that produce the mucus. Remember, it's epithelial tissue. And in this case, they're showing you it as pseudostratified because of the nuclei being scattered. So it's pseudostratified, ciliated columnar epithelial. Okay. Again, browse through this picture and the previous one. Next slide. This slide is the one that you want to write down so you have an idea of the type of epithelium throughout the tract. Now again, remember the rule. Changing in the structure probably relates to changing in the function as well. So as you can see, we start off with pseudostratified in the nasal and the upper portion. Then we go to stratified squamous, pseudostratified ciliated again in the upper portion of the lower respiratory, and then we end up with cuboidal epithelium towards the bronchioles. Okay. So again, get a feel for the pattern of the epithelial tissue. Next slide. Okay. Notice what it says. Alveolar epithelium. We're now in the alveolar area. Very delicate, simple, squamous epithelial. Okay. And that's for, again, very thin lining for gas exchange. Okay. You can easily tear these, you can easily balloon them out. So you never want very strong, forceful air, as high pressure air coming into the lungs. You can actually shatter these. Okay. Next slide. Okay, having talked about germs and debris, we have respiratory defense system. Consists of a series of filtration mechanisms to do what? Remove particles and pathogens. Now the next slide expands on that thought. We have our cilia that you saw a moment ago. Remember I mentioned it's sort of like an escalator going up by way of the cilia. We have our mucus cells already shown in that last picture. And what does it really do? Our nose, for example, serves as a filtration. Right? So our nose, that nasal cavity, will serve as a filtration. That is why it's better to breathe from your nose than your mouth. Okay, so it acts as a filtration. Okay. Then the very last one you may have received in 2402's chapter on lymphatics. We talked about the alveolar macrophages, often called dust cells. So these are your macrophages in your lungs area that are designed to eat up germs that are there. So alveolar macrophages or dust cells. Next slide. Okay, now we're moving into the structure, and that takes me towards page 817 and beyond. Now, on those pages, the first thing you see is the nose. Okay. Now, most of us already know what the nose involves. So you have our nose, our nostrils, that type of thing. Okay. So be having a general understanding of this slide. Don't care too much for it. Remember, we already know that nasal hairs serve what purpose? Filtration. Next slide. We have our nasal septum that divides the left nasal cavity and the right nasal cavity. This is the nasal septum that a lot of people have as deviated nasal septum. And this is what happens to people who often snore. So if they're snoring, that nasal septum may be a reason for it. Now, in the same nasal cavity area, we have the olfactory region that produces the sense of smell. And of course, that area has the paranasal sinus and tears and mucus, which actually cleans and moistens the nasal cavity. So if you had to look at the functions of the nasal cavity, you would say it like this. Sense of smell as a function of nasal cavity. Clean, moisten, and warm the air. So it'll actually warm up the air because you don't want cold air going down into your lungs. So it sense of smell, cleans and moistens the air, and filters the air as well. So cleans, moistens, warms, filters, and sense of smell. Okay, so those are your functions. Next, airflow. Okay. Now, I don't care for this language up here, but we're going to see that there's another term that a lot of authors use, and we'll see that in a picture form. Now, a moment ago, I already told you that it does what? Warms, filters. That's what TRAPS particle relates to. So it warms the air, filters the air, cleans the air, moistens the air, sense of smell, all of that. So that's, again, part of the last slide as well. All right, next slide. The palates. Now we have a hard palate that forms the floor of the nasal cavity, and we have soft palate. These two right here on this slide, they're best actually seen instead of written down as a slide. So we're going to see this as a picture in a moment. Okay. This slide again is a summary of what we've already said. Notice that the author says the same thing down here. Breathing through the mouth will bypass this important step. That is always a good idea to breathe through the nose, not the mouth. Again, what will the nose do? Warms, filters, moistens the air along with the sense of smell. Okay, next comes this picture. Have a general understanding of this picture. Not too important for me. Have a general idea for this picture. Next slide. Okay. Here's another view. I'm on page 818. So here's another view of that. Okay. This is again a frontal section shown by this diagram here. Again, not too concerned with this one, but I do like the next one that's coming up, and that one is important. So I have a general idea of this one. Again, as I mentioned earlier, it is important to know the hard palate versus the soft palate, but in picture form is better. So hard palate. Next slide. Now this picture is very important. Page 818 at the bottom, picture C. So page 818, picture C at the bottom, very important. This one has a lot of what needs to be learned. First, I'm going from the clockwise position, frontal sinus. Then we have the nasal concha. And again, earlier I mentioned something about that when the author used a different term. So the author used a different term on page 815. They just said nasal concha and that's it. Well, there's three parts: superior, middle, and inferior. And often authors will replace this term or substitute this term with turbinates. So nasal concha, nasal turbinates. And you have your superior, your middle, and your inferior. Now, why do they call it concha? Well, the snail shell has different areas for air turbulence. That's exactly what this will do too, as turbinates or nasal concha. So you have superior, middle, and inferior, and it actually vibrates the air in that region. Next, we have the vestibule, basically just the opening to get into that channel. We have the external nose. And here's that story about the hard palate and soft palate. Again, I said that it's important to see it in picture form. So here's your hard palate, and followed right behind in the back by the soft palate. Okay. Then we have the oral cavity, the tongue. We have our tonsil in the back, the palatine tonsil in the back. That's often what gets infected easily. Then we have our bone structure, the mandible. We have our lingual tonsil in the back, our hyoid bone that we've already learned about. And here's the rest that's important. You have your thyroid cartilage. And of course, it makes sense because the thyroid's right there. We have the cricoid cartilage. Again, this is a side view, so it's not as clear, but we'll see it in another slide. So we have the cricoid cartilage, part of the larynx if you really wanted to call it that. Then we have our trachea, and we'll see more about that. And then we have our thyroid gland up here. On the opposite side, we have the esophagus. So that's another good test question. What's anterior and what's posterior? Well, it turns out that the trachea is anterior and the esophagus is posterior. We have our vocal folds, and then we have our glottis. Now, this is sort of a poor way of showing it because glottis, by definition, is actually the passageway within the larynx. So what is the passageway within the larynx called? Glottis. Okay, so the passageway within the larynx is the glottis. Then we have the epiglottis. Now this is the fold that will actually close off, and it'll actually bend down and close off the passageway. So therefore, food and drinks do not end up down your air pipe and into your lungs. Okay, so this is a fold that we'll talk about, the epiglottis. Then the pharynx. And again, I told you that the pharynx is what? The back side of your mouth. Now, just as a clarification that we'll see later in chapter 24 on digestion, this area is your oral area, your true mouth. Authors sometimes call this area here pharynx proper. So some people will call this oral pharynx, as this author has done, or this area right here is sometimes called pharynx proper. We have our nasopharynx. This is why if you put stuff in your mouth, like milk, and then someone says a funny joke, and all of a sudden the milk comes out of your nose. So there is a connection between the nose and the pharynx. Okay, so the nose and the pharynx, the nose and the mouth have a connection. Then we have the laryngopharynx. This is the region where things can get trapped in terms of your choking. So when someone is choking, this is often where it gets trapped. And then you do the Heimlich maneuver, hit them in the back or whatever it is, and then it gets dislodged. It'll either go properly down the esophagus, up through the nose, or back out in the mouth. Okay. And then we have our internal nares as opposed to external, and then that's the nasal cavity. Again, you see tonsils in different places. They're all part of the immune system. Okay. So make sure you're comfortable with this. Now, look what it says here. Entrance to auditory tube, right there. This is where if you eat something, or if you have a lot of mucus in your nose from a cold, it can actually go up this auditory tube. So at the roof of your mouth, if you opened your mouth up all the way open, like on the old Reach toothbrush commercials, you would actually see this opening that goes into the auditory tube. At the very end of Biology 2401, you actually learn that. And this would actually head up into the middle ear. So this tube would head up into the middle ear. Okay, next slide. Okay, here's the pharynx. I've already covered much of this, but this slide is worthwhile going over. So what's the pharynx? It is a space shared by both the digestive system and the respiratory system. So that bullet is important. The three parts we saw in the last slide, they're also listed again. Again, Nemish calls oropharynx pharynx proper, as most instructors do when it comes to the next chapter, chapter 24 on digestion. Here we have an expanded view of the same thing. This is worthwhile looking at, but you wouldn't really want to write it down. Okay, so this is worthwhile looking at, but you don't need to write it down. Airflow. Okay, the larynx now. So we've got ourselves to the larynx. Remember I said the pharynx leads to the larynx. So the pharynx leads to the larynx. I've already mentioned in the previous picture that glottis is the passageway through the larynx. So glottis is the passageway through the larynx. I've mentioned this in the last picture. We talked about the epiglottis, the cricoid cartilage, and the thyroid cartilage. Again, writing this slide doesn't mean anything. This slide is of importance. So this slide is worth making a note of. It is made out of hyaline cartilage. Yes, very much like the end of your bone, right? You have hyaline cartilage at the end of your bone that later turned into articular cartilage. Then the next important one is the Adam's apple, which we primarily know. So this is what guys have an extension of, the Adam's apple. And then you need to know that they are attached with ligaments. So this cartilage, this thyroid cartilage, is held in place by ligaments. Okay. So that's worthwhile noting as well. So this slide is important. This one is an extension. I don't care too much about this one, but I do need to know that it's made out of what? Hyaline cartilage as well. Now this slide, the previous slide, and this slide that I've now moved to, epiglottis, it is elastic cartilage. Again, we see words like ligament. Those three slides, thyroid cartilage, cricoid cartilage, epiglottis, I want you to see it from the picture point of view, and I want you to understand what they are. Next slide. Here's why I said you need to know what they are. And notice, cartilage is what? Pliable, flexible, unlike bone. All right. Now, why is that important? Look what it says on this slide. It supports and protects, like all connective tissue, because cartilage is a connective tissue. Notice it says during swallowing, the larynx is elevated. It prevents the entry of food and liquids into the respiratory system. So this thing is actually what? Flexible. That's why I want you to summarize this slide that way. Why cartilage? Because it's flexible, and you need that. So it supports, it protects, but it's also flexible. Next slide. These three are parts of the larynx. You'll need to know them from not this perspective, but the next three slides. So let's go through these next three slides. Here's slide number 1. You need to be able to label this picture. We've already talked about the hyoid bone. So this is now a frontal view, the hyoid bone. We now have the epiglottis. Here's the thyrohyoid ligament. And notice it's a ligament. Okay, so the thyrohyoid ligament, again flexible. The larynx itself, and there's that prominence, which is the thing that juts out in guys. Another ligament, and then we have our thyroid cartilage, this big region here, the cricothyroid, and the cricoid cartilage, and then the tracheal cartilage is down here. Okay, so be aware of this picture. Now I'm going to stress this tracheal cartilage down here. They're actually in the shape of the letter C. So they're C-shaped cartilage rings. Again, why cartilage? Because it's flexible. And these C-shaped, like the letter C, the C-shaped cartilage rings allow the trachea to expand and contract, especially when air is coming in and when air is leaving. But it does what though? The C-shaped cartilage rings prevent the trachea from collapsing. So if we exhaled like blowing out a balloon or blowing out candles, what would happen if it did not have any of this supporting cartilage rings? The trachea would collapse at the time of exhalation. We don't want that. So that's why we have C-shaped cartilage rings that keep it in place. Next slide. Here's the back view. We again see the epiglottis. And this time around we actually see the area of where you're going to have your vocal cords. So the area of your vocal cords. And all of this passageway. So the passageway here is called glottis. So the passageway is called glottis. Again, this time around you actually do see what? This time around you actually see the C-shaped cartilage rings. Let me back up a slide. There we go. You can see the C-shaped cartilage rings. Next view. Again, you see it as a C-shape. They're not continuously as a ring. So they're a C-shaped cartilage. Let me show it again. See how it goes almost all the way around. Okay, next slide, this one here. There's your epiglottis. What is this passageway going to be called? This passageway is going to be called glottis. Okay, so epiglottis is the flap, and here's the passageway, glottis. So this is again a sagittal or a side view cut. Make sure you're familiar with these three slides. Okay, next slide. Here we have our cartilage function continued. Notice that these two cartilages here play a role in opening and closing the glottis, and that helps with sound production. Now, sound, as you learned in Biology 24:1 at the very end, that sound had two properties. Frequency was one, and frequency had another name called pitch. Then the other property of sound was loudness, also called intensity. Now, when we talk about those terms about what sound is frequency and intensity, or pitch and loudness, but it's really what? It's the frequency of the sound, the pitch of the sound. And this is what we're talking about. The pitch of the sound is related to this cartilage function. So when someone sounds like Donald Duck, and you've used some kind of synthesizer and you now sound like Donald Duck, what did you do? You changed the frequency of your voice. And that is how you're able to produce the sound of Donald Duck. Now, when an opera singer, or some of these new singers you see on American Idol, those singers who can stretch that note and hold the sound at lower volume and high volume, they're able to do that because of the passageway of air going through the larynx. More air goes through, the louder the sound. Less air goes through, softer the sound. Okay, so that's how that works. Next slide. Okay. Again, on this slide, nothing more to say, but I do want you to browse through this slide right here. Here's the extended view of the same thing. Now, this is what I was speaking of a moment ago, sound production. Air passing through the glottis. It vibrates the vocal folds, produces sound waves based upon frequency and loudness. Okay, so that's how that works. Next slide. Let me back up for a second. Here we go. This is the slide that I mentioned that you need to know in terms of how air goes through the larynx and produces sound. So we have speech. And again, this is all related to the words of frequency and intensity and how the vocal cords play that role. Okay, having said vocal cords, here's what the vocal cords would look like. Here's the top view. You can see that we have the glottis. It is being affected by the vocal cords right here. Remember, these are what make up the vocal cords. Okay. And here's the epiglottis. And that would be the passageway. Now, be aware of this picture. So this picture is important. Here's another view of the same thing. In this case, the glottis is now closed. Next slide. Here's a view of an actual picture. Again, glottis opening. Here's your cartilage that makes up the wall of the opening and your vocal cords. Again, be aware of what this is. Next slide. Okay. I don't care too much about this one. On this one, I don't care too much about this one either. This one, don't care too much about that picture. This slide, don't care too much about. This one I do. This slide is important to keep in mind. We're now going from trachea down to primary bronchi. Okay, so primary bronchi. So from trachea to primary bronchi. This picture here, or the slide, doesn't make sense, but this picture does. This picture I do want you to know. Notice I am a big fan of pictures because they show you the primary bronchus, secondary bronchus, and if I went one step further, I would see the tertiary bronchus. Okay, so primary bronchus, secondary bronchus, and if I went further, tertiary bronchus. You see the tracheal cartilages mentioned earlier, and you see this term right here called the carina, which is just at this tip right here. So right at that branching, you have this piece right here called the carina. Next slide. This slide, I just want you to have a general feel that there is what? A lot of blood vessels going in and out of this region. So a lot of blood vessels going in and out of this region. Next slide. This one you do need to know. So we have our left lung, right lung. They are covered by what? Pleural cavities. This is very similar to the heart having the pericardial cavity with the pericardial sac. So this is very similar to that. So lungs do have an outer covering called the pleura, and between the pleura and the lung itself is the pleural cavity. So that part is important. Next slide. The right lung is made out of 3 lobes. That is important. So the right lung has 3 lobes, superior, middle, inferior. The left lung has 2 lobes, superior and inferior. Now when it comes to these terms right here, the oblique fissure, it is best to see it in picture form. So that's coming up. Next slide. Lung shape. The right lung is wider, and of course it is pushed upward by the liver. Now where will you really see this? It's nice to see it as a slide, it's nice to see it as a picture in our PowerPoint, but it's best to see it on the model during lab day. So when you come in for lab day, it is very important that you actually see this on the model. That is true for every single picture I have shown. Can you see it on the model? It's nice to have it in the book, it's nice to have it in the PowerPoint, but you want to see it on the model. Now earlier I mentioned left lung. Left lung had the cardiac notch, and that was mentioned before. Next slide. Here's the picture version, showing you the right lung with the superior, the middle lobe, and the inferior lobe. You see the indentations or the markings called the fissures that separate them out. On this side, you see the left lung. This little indentation is where that cardiac notch portion would be. Okay. Next slide. Here's a picture version. This one is important. Again, you can see the horizontal fissure, the oblique fissure separating the superior, the middle, and the inferior for the right lung, and the oblique fissure here separating out the superior and the inferior and showing you the cardiac notch. Okay. Here's the backside view of it, showing you the pulmonary veins and the pulmonary arteries. And this would be the lymph thing right here. So that would be a lymph part. But as you can see, they show pulmonary veins, pulmonary arteries. It is important. Okay, so pulmonary veins, pulmonary arteries, important. Next slide. Don't care for that picture. Next slide. This slide is important because now we're branching further down. So this one is the next slide. I do really not care for these terms, but just to be aware of this slide. So bronchial tree, breaking it from the primary bronchus, secondary bronchus, so on. Having said that, you now see this terminology here. Again, this is sort of an FYI type of question. Next slide. This one is important to keep in mind. The right lung has 10 pulmonary segments. The left lung has 8 or 9, depending on the size of that lung. So left lung, 8 or 9. Right lung, 10. I've already mentioned the primary, secondary, and tertiary bronchus story. This information down here is very important. Look what it says. Contains progressively less cartilage and more smooth muscle. Now, there is a theme that has been carrying over thus far, and that theme is very similar to the one in the blood vessel chapter. We said that arterioles in the blood vessel chapter had a lot of smooth muscle, elastic muscle fibers, and all of that. And I also mentioned that bronchioles, very similar to arterioles, will be excited electrically and chemically. Now, that's where this relates. Look what it says. Increased smooth muscle tension affects airway constriction and resistance. That smooth muscle that we're speaking of is electrically and chemically stimulated. That means the nervous system can play a role in the constriction of the airway or the dilation of the airway. So that's nervous system. That would be the electrical. Chemically, same thing. There are chemicals that can constrict or dilate these passageways, affecting, of course, resistance. And of course, resistance translates to air flow. Okay. So this bottom bullet on this slide is very important when it comes to the actual physiology or the action. Next slide. Bronchitis. Okay, so someone that has bronchitis has an inflammation of the bronchial walls, causing constriction and difficulty breathing because airflow is limited. Okay. So remember the rule, just like in the case of the blood vessel chapters, pooling is bad, while pooling of air is bad as well. You want airflow, not pooling of blood, not pooling of air anywhere. So bronchitis. Now, what do they often take to alleviate bronchitis? They take something that does what? Removes the inflammation, such as an antihistamine. That'll help with the inflammation of the bronchial wall. When an asthma patient has to take some inhaler, okay, such as albuterol, which is the common drug for asthma people, that's what they do. It decreases the inflammation, causes dilation instead of constriction of the airway. Next slide. Now, this slide is my main take-home story. Look at the bottom half. I don't care for the top, but look at the bottom half of this slide. Bronchioles have no cartilage, but are dominated by smooth muscle. Isn't that story very similar to arteriole story when it came to the blood vessel chapter? Arterioles are electrically and chemically stimulated. Bronchioles are electrically and chemically stimulated. Now, what do you think is going to happen on the next slide? It's going to expand on that. So what I've been saying all along is electrical chemical for arterioles, electrical chemical stimulation, bronchioles, because of the smooth muscles. Look at the next slide. What do you see here? Autonomic control. Diameter of the bronchioles, airflow and resistance. That's exactly what we said. And notice we were able to predict this slide in advance, because the moment you say arteriole, the moment you say bronchiole, having more smooth muscle, Nemesh's 95% rule kicks in with electrical and chemical. Next slide. bronchodilation, bronchoconstriction. Now, let's look at the top. Dilation of bronchial airways caused by sympathetic. Now, normally in arterioles, we would say it is what? We would say sympathetic arterioles, unilateral denervation, which basically means it's going to be sympathetic for constriction of the arterioles. This is the opposite. In lungs, the sympathetic is bronchodilation. So sympathetic is bronchodilation for the lungs. So more air actually gets to the lungs and from the lungs. So one more time, bronchodilation is sympathetic for the lungs. Had I talked about chapter 21, then yes, Nemish, sympathetic would mean the constriction of the blood vessel. So in this case, we have dilation of the airway, improving airflow. Then we have the opposite, bronchoconstriction. That's parasympathetic. Now remember, we did not have any counterpart like this in the blood vessel chapter. In the blood vessel chapter, it was sympathetic more or sympathetic less. That is not true here. Here we do have parasympathetic, and it's for constriction. Earlier in the last slide, I talked about the example of histamine. So someone that has an allergic reaction and has their nose all stopped up because of allergies to ragweed pollen, tree pollen, whatever pollen, what happens? The histamine swells up the nasal passageways and along with the bronchioles. And so when you have a constriction of the bronchi, you get swelling, and that constriction is bad. What do you take? You take Benadryl. Benadryl is an antihistamine. So when you have a cold and you have issues, histamine is bad, and you take Benadryl to counter that. All right, next slide. We've already talked about this. What happens in an asthma patient? Asthma patients have excessive stimulation, excessive bronchoconstriction, and we have what? Stimulation severely restricts airflow. What do? You take things like antihistamine. You take things like albuterol, which are bronchodilators. Okay, next slide. Okay. This slide, general information. I don't care too much about this slide. And we move to the next one. This one is important. So this slide is important. Now, before I begin this slide, I want to go over certain sections that I want to make sure I've covered, and that is page 817, the clinical box. So before I start on this slide, page 817, the clinical box. The clinical box talks about TB and cystic fibrosis. So what I have said thus far will relate to page 817 on TB and cystic fibrosis. Okay, now resuming with this picture, the page number I have gotten up to is now page 826. On this page, we see a picture showing the next stage. So after the tertiary bronchi, we go off into the bronchioles. And then from the bronchioles, we move further from terminal bronchiole to respiratory bronchiole. So now you can see what we learned at the beginning. Terminal bronchiole and upward was all conducting zone. So terminal bronchiole and upward was conducting zone. We're now headed towards the respiratory bronchiole and alveoli, which will play a role in gas exchange. Next slide. This slide is the next one down. So if you have a bearing issue, once you understand this picture, you could go back to the previous picture and see where you are. So we're now talking about what goes on in that alveoli. Here's the expanded view. So here we have our passageway coming in, and we have our alveolar air sacs, very much like little balloons. And inside this main alveoli area, we see these little alveoli pouches. So we have the alveolar sac as a whole, and then we have these little alveoli pouches. And here's the alveolary duct. Right about in this area is where you're going to see your dust cells, those macrophages. Matter of fact, you can see part of that lymphatic vessel that's going to relate to that. So that's why I said this area right here is where you're going to see your macrophages, your dust cells. Now, do you see how each one of these alveolar sacs are very tightly packed, tightly wound around like rubber band balls, tightly packed with blood vessels, the capillaries. You can also see from here we have our incoming. So this is our incoming. So we see our pulmonary artery incoming, and then we see our pulmonary vein leaving. Remember, the pulmonary vein is what's going to go back into the left atrium. So pulmonary vein, left atrium. This thing right here, all this ball of mess, is going to be the capillary. So again, you see your AACVV, but this time the colors are reversed. Remember, I said that veins and arteries are never based upon color, they're based on direction. Now, the other thing to get out of this important picture is this one. Here we see the visceral pleura. Then we see the pleural cavity, the space, that's what a cavity is, pleural cavity. And then we see the parietal pleura. So just like the heart, we have a sac covering it. The heart was called pericardial sac. The lungs will be called the pleura. You never want to break this space right here, this no man's land of pleural cavity. It does have a fluid in it, just like the pericardial sac, but you never want to tear into that. Otherwise, the atmospheric pressure issue will come into play, and we'll see that later. Next slide. This one right here, for all of this on this slide, I'm very concerned only with the last bullet, which I've already stated. So the terminal bronchiole turns into respiratory bronchiole, where gas exchange takes place. We've said it enough times. Next slide. Alveolar ducts. I really don't care too much about this, but I only care really about that last line, surrounded by elastic fibers. And that will play a role later. Okay, so not too much about this slide except that last bullet. Next slide. Here's another view of it. Next slide. Here's a better view showing you the sac itself and then the alveolar indentations. Next slide. We've already talked about this. We've already mentioned dust cells, alveolar macrophages. We already know that it consists of what? Simple squamous epithelial. We saw that at the beginning of the chapter. So simple squamous epithelial, and it contains or patrolled by alveolar macrophages. Next slide. Surfactant. This slide is very important. What is surfactant? It is a detergent. That's why it says oily secretion on the slide, surfactant. It contains phospholipid and proteins, and its job is to coat the alveolar surfaces. It reduces surface tension. Now, here an example is important. If you buy a brand new bag of balloons for a party, and you just take out the balloon directly from the package and try to blow it up, because the rubber molecules of that brand new balloon have not been sort of stretched out, blowing up that balloon becomes difficult. However, if you stretch it a little bit here and there before you blow up the balloon, it becomes much easier to blow it up. That's the same concept as surfactant. Now I'll give you one more related to these examples. One more. When you have a balloon, a bubble that the kids blow up with detergent and water, that little bubble, it'll easily pop. So if it lands on a surface, it easily pops. However, if you have these party bubbles that they sometimes give out to kids with glycerin in them, and you may have seen those, you'll see that what happens is that the bubble actually stays longer. So if it hits the surface of the sofa, for example, it actually stays as a full bubble. Now, what is that bubble? It's an air bubble. The molecules of the water are holding that bubble in place. And if the detergent is able to hold the bubble, everything's fine and dandy. The moment that the bubble can no longer hold, what will happen? It'll collapse. So when you have an oily surface, which is what soap water is, what happens? The bubble forms because the molecules next to the water molecules are able to stretch a little bit. That's exactly what this does. Surfactants allow the alveoli to stretch. If the air bubbles or the water molecules in my example are not allowed to stretch, the bubble will collapse. Now, where does this play a role? It plays a role in premature babies. In premature babies, they do not produce this surfactant, this detergent. And since it's very poorly produced in the premature baby, every breath that they take in trying to expand that alveoli sac becomes very painful. Now, a moment ago on a previous slide, there was a term called elastic fibers. Well, it plays a role here. When the alveoli stretches, when you inhale and the air comes in, that alveoli is going to stretch. And if the surfactant is not there, then the alveoli will want to collapse on itself. And therefore, less air, and it becomes a very painful inhalation. So when they're trying to inhale, the alveoli can't stretch. Less air is able to get in. However, if you do it the other way with surfactant, the air sacs can actually expand. Now, the problem is not just only the inhalation, but it's also the exhalation. When you actually exhale, the bubble will collapse. Then what happens after you exhale? Don't you want to inhale again? Well, what happens if you don't have the surfactant? You can't do what? Inhale again well. That alveoli will not want to expand again. Just like when you buy the brand new balloon I mentioned, the new balloons don't want to expand because the rubber molecules are tight and holding together. The only way you can counteract that is to stretch the rubber molecules a little bit on the balloon, and then you can blow it up better. That's exactly what this is like. So inhalation becomes difficult, and then once you exhale, you have trouble inhaling again the second time around. What do? They actually get surfactant. Long ago, they used to take surfactant from a cow. They would take this cow surfactant from the cow's lung, squeeze it, purify it, and inject it directly into the alveoli area of the premature baby. And then in this way, the baby's lungs can then expand well. And they often call that respiratory distress syndrome. And that's what they call the problem in the premature baby. Okay. So surfactant is a very big deal. Next slide. Okay. So again, you see another view of it. These are the elastic fibers that I spoke of. Okay, so these are the elastic fibers that I spoke of. Okay, next slide. This picture here shows you the alveolar macrophages and the elastic fibers that I also mentioned in my story. Okay, so you want to overcome the elastic fibers that want to sort of collapse the alveoli. And the only way you can do that is by way of that surfactant. Okay, draw a line. Next slide. Here's the thing I mentioned a moment ago. Respiratory distress syndrome, often found in premature babies. What do I have? I have difficulty in breathing, especially the inhale followed by exhale, due to alveolar collapse. The alveoli do not want to do what? They don't want to stretch, very much like the brand new balloon. They don't want to stretch, so you have to stretch them first. In this case, it's achieved by lowering the surface area's tension among the water molecules and of the membrane. And notice it says, I'm not producing enough surfactant by the pneumocytes type 2. So not enough surfactant. Respiratory membrane, don't care too much about. We've been talking about that all along. We've been saying it's a thin membrane where gas exchange occurs. Next slide. This slide, don't care for. Here's a picture version of that. Don't care for it. Now, I've already been talking about this all the time. Remember I said, between a blood vessel and the cell space, it must be what? Short. So again, I don't care for the picture, but I want you to understand that between the alveoli and the blood, so between the alveoli and the blood, that distance is short. Why? Because of diffusion. So this area is short because gas exchange occurs by diffusion. Next slide. There it is. So lungs, diffusion. Remember I said the distance between the blood vessel and the cell space for the lungs, the alveoli, that distance is short. We already know that respiratory membrane is lipid soluble. So what's crossing that membrane? Oxygen and carbon dioxide. So oxygen and carbon dioxide can cross that cell's membrane's barrier. So oxygen and carbon dioxide. Now, before I go further, there is a tip I need to give you in advance. Yes, Nemish, oxygen is moving, carbon dioxide is moving. But what is making them move? And as we learned before in 2401 and in 2402 thus far, it is going to be a pressure gradient. Just like what opened the heart valves opened because of pressure gradient. Same way here. Oxygen will move because of pressure gradient. Carbon dioxide will move because of a pressure gradient. Okay, any questions, concerns on that comment? Now let's go to the bottom half of the slide. I actually had pneumonia long ago when the Dallas Cowboys and the Houston Oilers played in Dallas for the playoffs or whatever it was many, many years ago. When I had pneumonia, I had trouble breathing. Why? Because the distance between the blood vessel and the alveoli increased because of fluid filling. So if you fill up your alveoli with fluid, and pneumonia shows up nicely on an x-ray, it shows up as a filled up alveoli. So if the alveoli fills up with fluids, what happens to the distance between the alveoli and your blood vessel wrapped around that alveoli? It increases. Very, very important to understand that. So if we have a larger diffusion distance between the alveoli and a blood vessel. Again, it does relate to this previous picture. If I increase this distance, diffusion becomes less effective. And that's what this is talking about. Next slide. Okay, on this slide, we have a lot of stories to keep in mind, but for me, the most important one is the bottom. I don't care too much about the top, the bottom. Blood from alveolar capillaries. We already know about pulmonary veins. We know that the pulmonary veins are going to be rich in oxygen, right? Pulmonary veins are rich in oxygen, and it will return to the left atrium. But we also have this thing down here. It is also where ACE, angiotensin converting enzyme, is made. Now, why do I need this? This is where the RAA story that you heard of in the heart chapter and the blood vessel chapter. Now, we said renin, we said angiotensin, and we said aldosterone. Well, what converts angiotensin from one form to another? And that's the angiotensin converting enzyme. It converts it from angiotensin 1 to angiotensin 2. And that's done here by way of ACE. Next slide. I really don't care for this one, so we can pass that slide up. Okay. And I do care for this one. Blood pressure. In the pulmonary circuit, it's low. Why would you want to have low blood pressure going through the lungs? If you had high blood pressure going through the lungs, what would happen? You would be tearing the endothelium lining. Remember, endothelium is the lining of your blood vessel. And that endothelium must be thin, just like the alveoli membrane must be thin. Again, let's go back to this picture. What do you see here? Capillary endothelium. See how small that is. Even the alveoli membrane is what? Short. So we have a short membrane for the alveoli and a short membrane for the capillaries endothelium. So the blood vessel is thin, and so is the lining of the alveoli membrane. Now, what does that mean to me? Well, it means that if we have normally a low, that's fine. But we don't want to have too much pressure going through the lungs. You'll pop those blood vessels. Look what it says. Pulmonary vessels are easily blocked by blood clots, fat, or air bubbles. And of course, that would cause what's called a pulmonary embolism. So you never want your blood vessels in your lungs to ever plug up. Because if you've got blood vessels in your lungs plugging up, what will happen in your lungs? Pulmonary embolism would lead to what? Pulmonary edema. Again, you see the word edema or pooling involved here. So you never want that. And you never want too much blood pressure going through, and you don't want it too low either. Okay, so it has to be just right. Next slide. We've already referred to this before about the pleural cavity. So I showed you that picture already. Okay, next slide. Here's the story about the pleura. We saw this in a previous picture. Parietal pleura, visceral pleura, and we have a fluid in between. Now, unlike in the heart, where that pericardial fluid and that pericardial sac played a role, and then if you had an infection, you had things called pericarditis, that's fine. But in the lungs, it's very important because it plays a role in pressure gradient for air to come in and out of the lungs. So here it's going to be important in terms of playing that role. Next slide. On this slide, we have an error to fix before we move forward. On this slide, we have this definition that is incorrect. Now, we have actually three relationships, not 2. So according to Nemish, we're going to have the following 3 relationships. So we need to correct this slide. The first relationship is called pulmonary ventilation. Pulmonary ventilation is the relationship between the outside air and the alveoli. So pulmonary ventilation is the outside air and the alveoli. Next, we have external respiration. Again, this definition is incorrect for us. So external respiration is the alveoli and the blood relationship. So alveoli and blood is external respiration. The last relationship for me is internal respiration, and that is blood to cells. So the relationship between the blood and the cells is internal respiration. Now, if I were to take all 3 of them, pulmonary ventilation, external respiration, internal respiration, I would get this generic word called respiration. So if someone asks you on a test, what are the relationships that make up the word respiration? Respiration is pulmonary ventilation, external respiration, internal respiration. Okay, next slide. Now, as you can now see that they have used my term. Again, we're going to alter this slide a little bit, referring to the previous one. Pulmonary ventilation, again, is your outside air to the alveoli. These two, numbers 2 and 3 on this slide, are related to the external respiration I gave you a moment ago, where we have the alveoli to blood. Moving further to the next slide, we have this picture. So all I've done is change this terminology. So instead of using this one, I've just moved this term over here. So we have pulmonary ventilation, which would be this picture. Then we would have external respiration, which would be this picture. So external respiration would be that one. And then we have internal respiration as is. So pulmonary ventilation, external respiration, and then internal respiration. And all of those together make up the word respiration. Next slide. Okay, now we're going to do some terminology here. This word right here can be basically the same thing as saying anemia. Okay? Now, when we did the chapter on the blood, chapter 19, we actually had the word anemia. Anemia resulted because of 2 main reasons. Either I had just the right amount of red blood cells, but each red blood cell's hemoglobin was carrying less oxygen for whatever reason. So when we have the right amount of red blood cells, but carrying less oxygen, that can be anemia. The other reason for anemia is when we have less number of red blood cells to begin with. So we have less red blood cells, we have less hemoglobin, therefore we're anemic. Now, that's anemia. How is it related to this slide? Well, you could be anemic, but not be hypoxic. So you can have plenty of red blood cells, plenty of oxygen on your red blood cells, but you're not getting the oxygen to the tissues. So whenever you say hypoxia, it's when the tissues have a low level of oxygen. So you can have a lot of oxygen on your red blood cell in your blood, but if it's not being dumped properly into the tissue, then you have a problem with hypoxia. So low levels of oxygen in the tissue is hypoxia. Next slide. Pulmonary ventilation. Okay. Don't care for this. We pretty much discussed it. I've already given you the definition already as well. What was pulmonary ventilation? It's the outside air to the alveoli relationship. So outside air to alveoli. Now, Why, Nemish, don't you care for this bottom part? Well, it really does get involved, but I'd rather do it by way of a picture. Now, before I move forward, we have a law to keep in mind, and that law is called Boyle's law. Okay? And we're going to see him in a moment. But yes, Boyle's law deals with pulmonary ventilation. So Boyle's law, pulmonary ventilation. Now, Boyle's law is a physics law, but it does apply to biology here. And what that law says is that pressure and volume are opposites. They're inverse. They're opposite. So if pressure goes up, volume goes down. So if pressure goes up, volume goes down. If pressure goes down, volume goes up. So they're inversely related. Now, Nemish, I need a better example. Well, the better example would be something like a bellow. Now, a bellow is a little airbag that long ago they used to use to throw air into a fireplace when the flame is going on. So if you're starting a fire in the fireplace and you want the air to help flame so you don't have to blow it from your mouth, you used to use an airbag called a bellow. Well, how do I get air into the bellow? I expand the accordion bellow. And when the bag is expanded, what will happen? The air gets sucked in. Then when I squeeze down on the bag, what happens? The air goes out of the bag. So it's very much like a syringe. So let's take a syringe example. If I want to have fluids go up into the syringe, I pull back on the plunger of the syringe. What will happen? The volume will increase. So the volume of the space of the syringe will increase as I pull back on the plunger. So as the volume goes up, the pressure goes down. And when the pressure goes down, we commonly call that a vacuum or a suction. So the pressure goes down. And that's what draws the fluid into the syringe. When we want to administer whatever's in the syringe, we press down on the plunger. When we press down on the plunger, what happens? Greater pressure inside forces the fluids out. So as the fluid comes out, the volume actually decreases. So that relates to our next slide. Our next slide is this one, that pressure and volume are inversely related. Again, writing this slide is not useful. You need to understand the example that I provided. Next slide. Okay. So here's the pressure volume story. Higher the pressure, so if you have higher pressure inside, so you start off, okay, shrink. Okay. I don't like this picture. If it helps you, it's fine. Here's the description. Again, I don't like these pictures. They're not as good as the syringe example. And why is it important? Well, remember we said, how in the world am I going to get air into the lungs or out of the lungs? And we said that's the same kind of story as how do I get blood to come into the heart and leave the heart? Pressure gradient. And doesn't this line right here at the top where it says air flows from pressure, higher pressure to lower pressure? To me, instead of writing that garbage of higher pressure to lower pressure, understand it's a pressure gradient. And gradients go from high to low in this case. Then we have the respiratory cycle. Inhaling, exhaling. What do you think really allows us to inhale or exhale? Boyle's law. Pressure, volume difference. Next slide. But Nemish, how am I going to change the pressure and volume of my chest cavity? Well, what do we use? What does Tarzan use to raise his rib cage? He uses his ribs, his intercostal muscles, to raise his rib cage. He also changes the volume of his rib cage by his diaphragm. You can see that on the slide that we're now looking at. So our object of the game is to change the volume of our thoracic cavity. And we do that by the diaphragm and the ribs and intercostal muscles and other muscles along the way. Okay. Next slide, next slide. So as you can see, here's a diagram of a rib cage and your diaphragm here. Now, if you haven't learned it yet, the word diaphragm means bell, like a dome, a bell. And so that dome shape can flatten out when you want to inhale, and it can actually balloon up again to the dome shape when you want to exhale. So in this example, we're inhaling. So what are we going to do? We're going to raise our rib cage, like Tarzan would do before he calls out to his animals. So he's going to raise his rib cage and contract the diaphragm. So if you raise the rib cage and contract the diaphragm, you have a greater volume. A greater volume will do what? Decrease the pressure. So greater volume will decrease the pressure. Next slide. Now, do you see this one? P outside, P inside. And in this case, at rest, nothing's changed. So it says pressure outside equals pressure inside, no air movement. So now using Boyle's law, we're going to do what? We're going to change our volume. Okay. Notice it says volume will now increase. What did we do? We raised our rib cage and we lowered the diaphragm. We contracted the diaphragm. See how it says it nicely? Elevated the ribs and contracted the diaphragm. Remember, diaphragm is a muscle. In doing so, we raise the volume. If we raise the volume, what happens to the pressure inside? Decreases. So look what it says. Pressure within the thoracic cavity will decrease and air will now flow into the lungs. That is how you're going to inhale. Next slide. For exhaling, we do the opposite. We're going to bring the rib cage down. So we're going to bring the rib cage down and we're going to relax the diaphragm. Notice it says, bring the rib cage down and relax the diaphragm. That will do what? Decrease the volume. And when you decrease the volume, you're going to increase the pressure. And now air will move out of the lungs. That's it. That's the magic of getting air in and out. And again, that is the application of Boyle's law. Next slide. We have this slide on compliance. You do want to write this slide down. Okay, so you do want to write this slide down. These three last bullets down here are what test questions are banked on. So you're actually going to look at test questions banked on these three things: level of surfactant, the movement of the cage, and the supporting structures, especially these last two. Next slide. Now, when we talk about pressure, we got to go back to a little bit of the physics and the chemistry stuff. And that is, at sea level, the outside air at sea level is about 1 atm, or 1 atmospheric pressure. And 1 atm is about 760 millimeters of mercury. Now, notice the slide has a conversion there. That conversion must be important. So 1 atm is 760 millimeters of mercury. Now, if you're a weather person, we wouldn't be using millimeters of mercury, but we would be using what's called torr. Just mentioning it, no big deal. Now, you do want to know what the outcome of this is. This is at sea level typically. So if you go to Mount Everest, the atmospheric pressure will drop. It'll be less than 1. it'll be less than 760. So if you're going to Mount Everest, it'll be less than. If you're going to the Mariana Trench, which is the deepest part of the ocean, and you were actually not in a submarine, but rather just out there on your own with some scuba gear, I know it's impossible, but let's say it could be done. If you're in a scuba gear, the amount of pressure pressing on you would be much higher, something like 3 ATMs. So it'll be 3 times 760. And why I said it's impossible for you to be able to do that on your own with just scuba gear is the pressure would be so high on you, you would be squeezed to death. And you would not be able to take air in, right? Because what will happen? You can't exhale because you'll only do what? Squeeze all that stuff. So you can't even inhale and you can't even exhale. All right, next slide. Now, I don't care for this slide because it doesn't mean much, but the picture that's coming up is. Same is true for this one. Okay. And remember our rule. We don't want to have too much pressure in the lungs. It will pop your lung. It is like inflating a balloon with the wrong kind of inflation device. You take a party balloon and you take it to one of those little pumps at the gas station, it's going to pop that lung. It's going to pop that balloon very quickly. So, last 2 slides, general information only. This one, general information only. Again, it doesn't make sense unless you study the picture that goes with it. Next slide. Now, this is something that I don't really care too much about. There's just different ways of reporting it. Earlier I mentioned TOR. Notice it's usually used for things like weather people. Usually mention TOR. We normally in America use millimeters of mercury. Weather people talk about TOR. Some people talk about centimeters of water. And of course, what do? When we're filling up air in our tires, bicycle tires or basketball or whatever, we talk about pounds per square inch. It doesn't really matter what unit we talk about in. We can always convert from one to another. Notice how the author says, sea level is about 15 psi. 15 psi is about 1 atmosphere. So 1 atmosphere is 15 psi. Next slide. Okay. Respiratory cycle. This one is important. Make sure this slide you have down. You need to know what the respiratory cycle is by definition and what tidal volume is by definition. Tidal volume is the amount of air going in and out of the lungs at rest. So tidal volume, the air going in and out of the lungs at rest. Okay, they didn't add that, that should be added. At rest. Next slide. Injury to the chest wall. This slide is important. Now, Nemish, you mentioned something about pleural cavity, and you mentioned pleural cavity in relationship to how air comes into our body. If you actually had a pneumothorax, what would happen to you? Make sure you study that for the purpose of the test. What would happen to you if you had a hole in the pleura? I want you to think about that carefully. What would happen if you had a hole in the pleura? Okay. I'm giving you a hint. What would happen if you had a hole in the pleura? Okay. Next slide. This slide is important to study. So that way you have an idea of what happens to the pressure. So this one's important to study. Next slide. I've already mentioned that the diaphragm played a role. I also mentioned the intercostal muscles. especially the external. So the external intercostal muscles play a role. The author does a good job by mentioning other muscles as well. So it mentions other muscles playing a role. Next slide. Okay. Inhalation is always active. That's very important. So inhalation is always active. That means you have to do what? You have to raise the rib cage using muscles to raise the rib cage. There is no other way. That is why patients who have paralysis of the muscles involved in inhalation, you often see them wearing respirators, or you see them in iron lungs from the days of polio back in the 50s and 60s. Okay. So inhalation always active. Exhalation can be active or passive. Let me give you an example of that. In exhalation, which is passive, that is how you normally exhale. In this case, gravity is allowed to lower the rib cage. So you're not using any muscles outright to push down for exhalation, which is passive. However, if you move over to the active form of exhalation, like as if you are blowing out a party candle or blowing up balloons for a party, that would be an active exhalation. So blowing out candles or blowing up a balloon would be an active one. In this case, you're actually using the muscles of your rib cage to pull the rib cage down. And in doing so, you actually create more of a pressurized exhale. So more of a pressurized exhale. That's how you get more of your air out. So if you're just exhaling normally at rest, that would be a passive process. But if you're coming from underneath the water in a swimming pool and you've just ran out of air, you're now really blowing in and blowing out quickly, like in hyperventilation, that would be more of an active exhale. Next slide. These are the muscles that play a role in your breathing. This slide is very important. So this slide is very important. If you broke it down into a percentage, you will see diaphragm accounts for 75%, and contraction would bring air into the lungs. So contraction would bring air in, and we're dealing with 75% there. External intercostals assists, and it plays a 25%. And all of these are the other minor roles. Okay. Next slide. We've already seen this slide before, so we can pass that one up. And now we have a better picture of the different muscles. You should have already learned these in 2401. So if you hadn't, it's a good idea to look at this slide. But in essence, you should have learned them in 2401. Okay? And these are all your minor muscles shown here. Next slide. Continuation. Okay. On this slide, okay. Let me back up for a second. There we go. Okay, on this slide, we have pulmonary ventilation. Now this slide is important. So all along I've been talking about this slide, but I never gave it to you to write. This slide is now worth writing. So muscles used in exhalation. So we're now going in the opposite direction. So these are the muscles we use. Notice I'm using what this time? Internal intercostal. So internal intercostal is for exhale. So internal intercostal exhale. Okay, very, very important. Again, pictures for that. So as you can see, there are a whole lot more muscles to inhale than exhale. Okay, so a whole lot more muscles for inhaling than exhaling. Okay. Now notice it says active when needed. Okay, so active when needed. Okay, any questions on that? Next slide. Okay. I've already referred to this, quiet breathing versus forced breathing. So I've already referred to this, just make sure you study it. Okay. This is your quiet breathing. This slide is worth writing down. So this slide is worth writing down, especially terms like apnea. Okay, that's worth writing down. Next slide. We have elastic rebound. Okay. This is worth writing down. Now this was actually mentioned to you even though you didn't realize it. We talked about the elastic fibers that are right around, we even saw a picture earlier, right around the alveoli. Their job is to allow the alveoli to expand, but also to do what? Recoil back. Now, that's important. It says, when inhalation muscles relax. So this must be dealing with what? Exhale. When inhalation muscles relax. So this is part of your exhale. This is what allows the air to be pushing outward. Okay. Next slide. Here's your forced breathing, hyperpnea. Hyperpnea. Okay. So your forced breathing. This is the example I gave with the party balloon and the candle. Okay. Draw a line. Okay. Okay. Now onto this slide. Now, upon looking at this slide, a sharp student would say to me, you know what, that sort of looks like cardiac output that we learned in the heart chapter, where cardiac output was heart rate times stroke volume. This is very much related to that same concept, but except it's for the lungs this time. So we have a respiratory rate and we have a tidal volume. Very similar to cardiac output for the heart. Next slide. So as you can see, we have what? A very similar formula. Heart rate, this time it's what? Respiratory rate. Stroke volume, this time it's what? Tidal volume. So very, very similar. Now why are the stories so related? Cardiac output dealt with how much fluid is leaving the heart at any given point in time. Okay, so how much fluid is leaving the heart? Cardiac output. In the same way, respiratory rate here and tidal volume is measuring pulmonary ventilation. How much air is leaving the body and how much air is coming into the body. Okay? So volume of air and how fast the air is coming in and out. Okay. Now, why are those two stories related? Because our job as cardiovascular is to get the fluids to the lungs. So we're taking one story and bringing it to the lungs. The next story is to take it from the lungs and out of the body and back into the body, back into the lungs again. So your cardiac output must be somehow related to the pulmonary ventilation. If you get more blood coming to the lungs, then you should have also a lot of oxygenation from the lungs back into the blood. So if you want to get more CO2 out of the body, as an example, More CO2 out of the body means you got to have a greater cardiac output to get CO2 to the lungs. Once they're in the lungs have to do what? Get them out of the body. Likewise, more oxygen gets into the lungs, more oxygen goes from the lungs to the blood. So there are very related concepts. Next slide. Starting from this slide onwards, you're going to have a lot of definitions. Please put them on a flashcard. So definitions, flashcards. Now, earlier we learned that we have what's called a conducting portion, which was terminal bronchial and upward. And then we also have respiratory bronchial and downward, which was where gas exchange occurred. This slide talks about what's called anatomical dead space. Now, normally we have our conducting zone that I mentioned, and that's typically dead space. But what happens over time is that more and more of our lungs, which is our alveoli typically, is going to die out. And if we have more and more dead space, which is anatomical dead space, so we have an area of gas exchange that is now turned into a conducting area, then we have more anatomical dead space. And that is not a good thing. Now, if we look at the formula down here, we'll see why. Tidal volume is the amount of volume leaving, the fluids or the air leaving. If we have more anatomical dead space, what happens to my math? So let's make up numbers here. 10 minus 2, so 10 minus 2, which is 8, and I'm going to give it a flat rate here of 10. I will have 10 minus 2, which is 8, and 8 times 10 would be 80. Now let's change our numbers here. Let's make this still 10, but let's make this 5. Okay, so instead of 2, let's make it 5. So I got now 10 minus 5. So instead of 10 minus 2, I got 10 minus 5. That's 5 times 10, 50. So instead of 80, I now have 50. Let's make this a really big number this time. So 10 minus 8. So 10 minus 8 would be 2. 2 times 10 would be 20. So do you see that raising the anatomical dead space actually does what overall? Reduces how much air is moving in and out. And when I say air, I'm talking about usable air moving in and out. Okay. So increasing your anatomical dead space is not a good thing. Next slide. Okay. Basic information here, don't care too much about that. Now, this doesn't show up so well here as a slide, but it does show up much better as a picture later. So you can ignore that one. Again, very, very important. Look what it says. For a given respiration rate, increasing the tidal volume increases ventilation rate. For a given tidal volume, increasing respiratory rate increases alveolar ventilation. This slide is important for a scenario. Now, have you noticed this slide is very much related to this formula and very much related to the math I was doing on this slide earlier. So very, very much related. Next slide. I promised that you need to have flashcards. Well, you need to have flashcards for these 4. Resting tidal volume, expiratory reserve volume, residual volume, and inspiratory reserve volume. Make sure you know the definitions of each of those. They are now shown on the next slide. So here's the definition of each of those. Okay. Now, the one I want to stress is this one, residual volume. Residual volume is the air that's left in your lungs, which I call stale air. It's the air left in your lungs after you have squeezed all that you can out of it. Look what it says, after maximal exhalation. So if your lungs fully collapsed, like a balloon, fully flattened, like the way you get it from when you buy the bag of balloons and you get it right out of the bag, you know what shape it looks, right? So a party balloon looks flat like that. That would be your residual volume that's still left in that collapsed bubble, that collapsed balloon. Now, why is residual volume so important? Because if residual volume goes up, you're going to have more stale air left in your lungs that do not undergo gas exchange. So you're going to have more stale air left in your lungs. Now, the tendency is that as you grow older, you'll actually increase your residual volume because you're not going to be able to get all that air out. And it's stale air that's not been replaced. And you know stale air is like stale water, not good. Next slide. This is a continuation of your formulas. This is a continuation of your formulas. Next slide. Again, continuation. Now remember, all these that you wrote down on flashcards just now, you need to be able to work with them. They all play a role in telling the doctor how your lung is doing. You could say that these 4 measurements and those 4 terms that you saw are words that are like an EKG but for your lungs. That's what it is in my mind. Next, this is a picture version of all those terms you saw. So that's the picture version of the terms you saw. Next slide. Okay. I don't care for this. I do want you to know that the total lung capacity is typically around 5 to 6,000 mils. Okay. So I want you to know it's around 5 to 6,000 mils. I do want you to know that. So total lung capacity around 5 to 6,000 mils. Next slide. Gas exchange. Now, this slide is related to the stuff that you learned in 2401. We've already talked about this relationship, so that can be passed on. And we're moving to down here. 2 factors will play a role in how gas exchange occurs. One is the partial pressure differences of the gases. Oxygen versus carbon dioxide. Now, that means what is the pressure difference between the outside air and the inside air when it comes to the pressure differences? Oxygen has a value, carbon dioxide has a value. Now, here's how you understand partial pressures. Partial pressure is the differences in the pressure gradient among the outside, inside. Next, number 2, diffusion. Diffusion of molecules between the gases and the liquid. This is where a new law is going to come into place, and that's Henry's law. So we'll see Henry's law in a moment. You've all learned about Henry's law before, and here's how. Henry's law deals with how gases are dissolved in a liquid. So when you have a Coke can, a soda can, that is not opened, and you go shake, 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 and then open the soda can, because you added energy to the soda can by shaking it, the gas molecules that are really dissolved in liquid. So at the factory, when they made the soda, they actually dissolved carbon dioxide into the liquid of the soda. Then, when you pop open the soda can, what happens? The gases come out. The CO2 comes out of liquid. So we have stories about diffusion and Henry's law, which deals with all of that. Okay, draw a line. Dalton's law. Now, Dalton's law is the sum of all the individual pressures that make up the word air. One of the biggest mistakes that people say is, oh, oxygen, air, same thing. No. The true definition of air is that air contains oxygen and many other components. Matter of fact, air is actually mostly nitrogen. Okay, so you can't say air is the same as oxygen, and a lot of people do. Now, how do I figure out what the partial pressure is for each of these? Well, I have to multiply the percentage by the 1 atm, the 760 millimeters of mercury. That will tell me what the partial pressure is at sea level. So it'll tell me what the partial pressure is at sea level. Now, Nimish, are you trying to say that the higher up I go, I'll have to have a smaller value? Because remember I said earlier, the higher up you go. So instead of 760 millimeters of mercury, which you normally see at sea level, it may be, say, 740. And a percentage of 740 will, of course, be less than a percentage of 760. So does that mean that these things will be less in value as I go higher and higher in elevation? That's exactly what I'm saying. So if you went to Denver, Colorado at a high altitude, all of these values would be lower in terms of their partial pressures. Let's go to the next slide. We'll see how. We already know that the atmospheric pressure is what? 760 millimeters of mercury at sea level. However, according to Dalton, if we did Dalton's partial pressure, we'll notice that out of 760, we have a certain percentage of oxygen, a certain percentage of nitrogen, and so on. So here's your next slide. Look what it says. All partial pressures must add up to what? 760. So how do I figure out the partial pressure? What I do is I take a portion. So how much is a portion? Let's look at oxygen for a moment. So it's 21%. We're rounding that off to 21. So if I take 21% of 760, so 21% of 760 is about 160 millimeters of mercury. Okay, so 21% is about 160 millimeters of mercury for oxygen. If I took about 79% of 760 for nitrogen, it'd be, of course, much higher. Right, so that's how the partial pressures work. Okay. You draw a line. We're moving to the next slide, next topic. Now we have Henry's law. Now I briefly mentioned Henry's law before. So what is Henry's law? Well, it depends upon the solubility of that gas. So in the case of carbon dioxide dissolves pretty well, but then the moment that it changes pressure, what's going to happen to the carbon dioxide? Instead of being dissolved in a liquid like it is inside of a soda can, when you pop open the soda can, the pressure changes and therefore the gas actually comes out of solution. That's the technical language. It comes out of solution. Next example. Notice they're using the soda can as well because that's the classic example. So here it is, the soda can is sealed. Then, the moment I pop open the soda can, the molecules of carbon dioxide want to do what? Come out. So here, when it's sealed, it's pressurized. As it is pressurized, the CO2 stays dissolved in liquid. The moment it changes the pressure, it comes out of solution. That's what they mean by that. Next slide. That was the first one. And that was the second one. And notice it says it comes out of solution. It leaves the solution. Next slide. Solubility. Carbon dioxide is very soluble. Oxygen is less soluble. Okay, so that's important. Next slide. Okay, now, these are the pressures that you find in the pulmonary vein. The pulmonary vein. These numbers will play a role in going from alveoli to blood. Remember, this is pulmonary vein, which is my way of saying blood. So these numbers are going to play a role. Now, Nimish, I already see something here. You said earlier that oxygen, when you do the partial pressure math, 21% of 760, you said it was 160. That is correct. That is what it would be outside the body, in the word air, outside at sea level. Inside your pulmonary vein, it's 100. Nimish, I see something there. So if the outside air is 160 and your pulmonary vein is 100, then that means that oxygen has a driving force that wants to do what? Come into the body, and what would that be called? From outside air to alveoli? That's pulmonary ventilation. Hence, as a result, once the oxygen gets into the blood, once it gets into the alveoli, it'll then be able to be driven into the blood. So it's the pressure gradient that's actually driving the oxygen from the outside air into the lungs and then into your blood. Next slide. We've briefly talked about this before. I just want to show you the terms. So again, we've seen it before. Those are the terms. Next slide. Diffusion and respiratory function. As you've noticed, diffusion and the direction is all based on what? Partial pressure differences and solubilities. So this is sort of a summary slide to let you know that diffusion is based upon the partial pressure differences and the solubilities. Next slide. Now this slide is very important. The author has thrown in certain slides that are very good review slides. This is one of them. So we've already said that one of the driving forces is that partial pressure difference. That is why the higher up you go in elevation, the tougher it is for oxygen to want to come into your lungs and in your blood. Let me give you an example. I'm a pretty good runner, but I had my daughter in a little fanny pack or a baby pack on my back, and I was running on the glacier in Switzerland. It is at nearly 13,000 feet. Okay. Guess what? I had trouble running because at 13,000 feet, the elevation is so high, oxygen levels are so low, the driving force becomes less. Okay, so that's number one here. Number two, distance. Remember, you do not want to increase the distance between the alveoli and your blood. So if you have pneumonia, as I mentioned before, pneumonia means fluid buildup in your alveoli, and that's going to cause a diffusion distance to increase, and diffusion is not very good at larger distances. So as long as I keep the distances involved in gas exchange should be short. So the larger the distance, the worse the gas exchange. Number three, lipid solubility. For some reason, if you change the solubility of the membrane, you're going to have a problem. Number four, surface area. If you start having emphysema and you have less and less alveoli for gas exchange, that's going to cut down on your efficiency because you're going to have less surface area for gas exchange. So you have to have the right surface area for gas exchange. you have to have the right distance for gas exchange, and you have to have the right partial pressures of the gases to make that work. The last is blood flow, airflow. Wait a second, Nemish. That last one there, number 5, blood flow, airflow. I think you mentioned that earlier. That is correct. You want to have the right blood flow going to the lungs and the right airflow coming out of the lungs, just as you want right airflow coming in and you want the good blood flow going out back to the heart again. So you don't want edema anywhere. You also don't want air to collect anywhere. And that is why the blood flow and airflow must go together. Now I'm going to go ahead and give you this hint. Number 5 goes with a word that's called perfusion. Perfusion. So blood flow, airflow will go with the word perfusion. Okay, so this slide is very important. Matter of fact, it's these 5 factors that if you mess up, you have trouble with a capital T. Okay, so you're going to have a problem when you mess up any of these 5 situations. Next slide. Now, this is dealing with that first bullet on that previous slide. Partial pressure difference. Look what it says. The concentration gradient causes oxygen to enter the blood and CO2 to leave the blood. So it's the partial pressure difference. Now, look what it says here. Blood arriving pulmonary arteries. That is your oxygen poor but carbon dioxide rich blood. Now notice what it says here. Blood that is coming into the lungs. So the dirty blood or the deoxygenated blood that's coming into the lungs has a high partial pressure. High in comparison to who? The outside air. So if we went back and did the math for the partial pressure of carbon dioxide at sea level, it would be much lower in the air than it is in your blood. Again, what does that say? Nemish, is that a driving force that says carbon dioxide is going to want to go from my blood to the alveoli and then from the alveoli to the outside air? That's exactly what I'm saying. That's a very big story. So because of the high partial pressure in our blood, less so in the alveoli, and even less in the outside air. So it is the partial pressure difference that's driving carbon dioxide out and oxygen in. Does that make sense to everyone? That's a major story. So carbon dioxide wants out of our body, oxygen wants into our body by way of partial pressure difference. Next slide. Okay. Now look at what it says here. Again, we're dealing with partial pressures. Lowers the partial pressure of oxygen entering the systemic circuit. Drops to about 95. Okay. Again, how much is it in the outside air? The outside air is 160. It's about 95 down here. Now when you do that, what happens? Oxygen wants or has a tendency to go into your blood from the alveoli. Next slide. All right, this is now in the interstitial. Now what does that mean? Interstitial is between what relationship? In the internal respiration, between the blood and the cells. So this is related to the relationship between the bloods and the cells as well. It's very close to that. It's getting there. Next slide. It's getting there. Now, this picture is very important. Look what the term I'm on. I'm still on external respiration. So I'm on external respiration, and look what's happening. Remember, things move because of a driving force. So now, what do I see here? I see pCO2 at 45. But what do I see as alveolus? 40. Remember, high to low. So 45 to 40 means it wants to go into the alveoli. Over here, for oxygen, it's 40. Over here, it's 100. Over here, it's back to 100 again because it's the same pressure as the same driving force. So these two numbers are actually related to the same concept. That's why it's 100 and 100. But what was it down here? 40. What's it here? 100. What do you know about it? 100 wants to go towards what? 40. For CO2, it's 45 wanting to go towards what? 40. This right here explains why CO2 wants to go into the alveoli and why oxygen wants to go into the blood. 100 versus 40 and 45 versus 40. That's the driving force. Next slide. Now we have the same story in the internal respiration. Same story. Check this out. Oxygen is 95. Oxygen in the cell, in that cell space, in that cell, it's what? 40. 95 towards the 40, from high to low. For carbon dioxide, it's 45, but it's also what? 45 here, and it's 40 there. Nimish, that doesn't hold true. There is a different reason here. It's close. 40 versus 45. Here, 45 versus 45. What's the difference? There's another third reason as to why CO2 wants to come into the blood even though it's so close. And that difference has to do with how much CO2's concentration gradient is. We have more CO2 here, less here. So the more CO2 wants to do what? Go into the blood. So it's not just partial pressure, but it's also the solubility story mentioned earlier. Remember, CO2 is more soluble than oxygen. Next slide. Now, much of what I've just said is actually in the next couple slides that you can copy. Okay, so this is basically the same thing. Okay, next. Okay, now, one of the things that you have to understand is something we learned before. And it was just a story before, and now it applies. At rest, we do not use all of the oxygen that is on the red blood cell. So let's say that again before we move on. We do not use all of the oxygen that is on the red blood cell at rest. So if we looked at it as a typical one hemoglobin story, we know that hemoglobin has 4 hemes, right? 4 hemes, 4 irons. At rest, we only pop off 1 out of 4 hemes. So 4 irons, 4 oxygens, only 1. So we're only using 25% of the oxygen at rest. So we do have reserve. Now, when we pop off that one oxygen, we're going to pick up what? Carbon dioxide. Now there's a driving force to that. That's our next slide. So having said that, look what it says. Oxygen binds to iron, hemoglobin. We've already learned that. We even learned this, oxyhemoglobin, before. And we also learned that each red blood cell has about 280 million hemoglobin molecules. And a moment ago, I told you that each red blood cell has the ability to bind to 4 oxygens. So we said that, and now it's repeated again. So we're only using 1 out of the 4 at rest. Now, that means that we're going to pick up carbon dioxide along the way as well. So we're going to pop off oxygen, and we're going to pick up carbon dioxide. It's that driving concentration difference that's going to make a difference. That means that the more oxygens I pop off, so if let's say I pop off 3 instead of 1, the more oxygen I pop off, the more carbon dioxide I'll be able to pick up. And it makes sense because that oxygen is going to produce what within the cells by aerobic respiration. We're going to use that oxygen to produce more carbon dioxide aerobically. Now, having said all that, look what it says. Hemoglobin saturation. So how much of my oxygen is sticking to hemoglobin? We already know that at rest it's pretty much full. We're only using a 25% typically. Now these are the 4 factors that you need to keep in mind that affect how much oxygen stays on your red blood cell. So how much oxygen actually stays on your red blood cell? The partial pressure of blood will play a role. So if you don't have enough oxygen in the outside air, we're going to want to try to do what? Keep as much oxygen as we can in your blood. Okay. Blood pH. That is one of the things we learned. Blood pH is 7.4 as an average number, right? 7.4 for blood pH. If your blood becomes acidic, that means we have done what? We're going to dump off more of the oxygen and pick up more of the carbon dioxide. So if your blood becomes acidic, that's not necessarily a good thing because you're not going to have enough oxygen moving around your body because it's going to be dumped off. So when your blood becomes acidic, you actually dump off more oxygen and pick up more carbon dioxide. So your blood becomes acidic. Same as for temperature. And so the higher the temperature, the more oxygen you utilize. Then comes metabolic, and that's what I mean by aerobic earlier. So the more metabolic, the more aerobic. Okay, next line. Okay, now this slide is very, very important. The part that's important is especially these 2 down here. Each oxygen bound makes next oxygen bind easier. So if you have more oxygen on your hemoglobin, the more oxygen can bind. The more oxygen that pops off, the more oxygen wants to pop off too. It's a little like monkey see, monkey do. More oxygen comes on, more oxygen comes on. More oxygen comes off, more oxygen comes off. Okay. Next line. Okay. This we've already learned. Oxygen diffuses from peripheral capillaries and into interstitial fluid. This difference right here is why oxygen wants to go into the cell space. I showed you that earlier before. Okay? So I showed you that in the picture form. The high in the capillary, low in the interstitial fluid, this is why oxygen wants to come off. Now that last bullet down here, we've already said. It says up to 3/4 may be reserved by red blood cell. What does that mean? What was Nemesh's comment earlier? About 1 out of 4 oxygens are removed from hemoglobin, which means we actually do what? Save 75% of the oxygen on a red blood cell on a hemoglobin. Only 1/4 is used up at rest, so we only use up 25%. That's where I came up with that number. Okay. So the more that stays on, the more that stays on. The more we started using it, the more oxygen pops off. And again, look what happens. The more I put into the cell space, the more it's going to go in that direction. Okay, next line. Carbon monoxide. This is a bad thing. Carbon monoxide is about 200 times stronger in binding to hemoglobin. So if you're in a fire and you got carbon monoxide around you, you want to be very careful not to breathe that in, because carbon monoxide, once it gets into your bloodstream, is going to knock off oxygen. So oxygen is going to pop off, and carbon monoxide will bind to hemoglobin. And this is sort of like musical chairs. As long as carbon monoxide is stuck to a hemoglobin, fresh oxygen cannot bind to it. So you really can't just simply take this person who is suffering from carbon monoxide poisoning and simply take them to fresh air and hope and pray that everything turns out right quickly. It won't. You're going to need an oxygen mask and forcefully push oxygen in, because oxygen will not have that driving force anymore to go to the cells that will instead want to pop off the hemoglobin and not tag on hemoglobin anymore. So that's not a good thing. All right, now we said blood pH is 7.4. Okay. We said that when the temperature rises, so when the temperature goes up, when pH drops, so it becomes acidic, so when blood becomes acidic or temperature rises, more oxygen is released. Okay. So if your blood suddenly becomes very acidic very quickly, you're likely to pass out. Why? Because oxygen is suddenly dumped right off of your hemoglobin, and instead of losing the normal 25% or 1 out of 4, you're dumping more oxygen suddenly, and you're likely to pass out. Okay. Now, instead of copying this, many books have a picture, so we're going to study the picture. Now, this is your picture for oxygen saturation. Never will it be 100%. Even the chart shows it. Never 100%. Why? Because at the tissue level, we're always doing what? We're always producing carbon dioxide. That's how we survive. We're aerobic animals. So as a result, there's always going to be some CO2 that's going to want to pop off oxygen. Remember, it's an exchange. It's like musical chairs. If oxygen pops off, CO2 wants to piggyback on that ride. So it's never going to be 100%. You're never going to have all 4 out of 4 on your hemoglobin filled with oxygen. I even told you that at rest, it's what? 75%, right? That's because we'll never get 100. Now, instead of writing all of this, because I'll come back to this in a moment, I want you to study the picture that goes with this next. This picture shows you what happens when your blood becomes acidic. So if your blood becomes acidic, you're now doing what? Carrying less oxygen on your hemoglobin. So if your blood becomes acidic, you're carrying less oxygen. Okay. If your blood becomes a little bit more basic, you have a greater ability to hold on to the oxygen that's on your hemoglobin. Okay. That's all it means. Now, have you noticed, how will my blood become acidic? By having more carbon dioxide produced. So the more carbon dioxide produced, you're going to carry less oxygen. So if for some reason you have suddenly a high degree of carbon dioxide in your body because you're not blowing it off and you're holding your breath, what will holding your breath do? Make your blood acidic and you'll have less oxygen on your hemoglobin. That's exactly what this slide says. So if you're holding your breath, you're causing this oxygen saturation curve to drop down this way. Okay, let me back up. We're going to do temperature next. So here's the temperature effect. So if you have a fever, so normally it's around here, and if you have a fever, look what happens with a fever. Higher temperature means less oxygen again. Okay. And if you are somehow able to cool your body down, that's what they do in emergency cases. They will try to ice your body down quickly so that less oxygen will pop off of hemoglobin. So if you cool your body down quickly, you're able to actually hold on to more of the oxygen because your metabolism is dropping dramatically when you cool your body down. Okay. So that's what this picture is. Okay. Here's the slide that goes with it. And here's the slide that I passed up and I'm going back to. This slide is important. It's called the Bohr effect. Again, notice it's caused by rises in CO2. So as you know that CO2 will be carried on a red blood cell, just like oxygen. So as more CO2 pops on, a red blood cell, here's what happens. We have an enzyme involved here called carbonic anhydrase. This carbonic anhydrase produces an intermediate step called carbonic acid. And then it says it dissociates into hydrogen ions and bicarbonate. And that's going to cause hydrogen ions to diffuse out of the red blood cell and lower the blood's pH. That's how your blood becomes acidic as you pick up more and more carbon dioxide. So if you hold your breath, but at the same time you're still alive because you're bouncing around while holding your breath, what's going to happen? You hold your breath, you're going to produce more CO2. It's going to piggyback onto a red blood cell. And when it does that, it's going to make your blood more acidic. And of course, that's going to have some bad outcomes. And the way you fix it is that you've got to do what? Your blood pressure will go up, your heart rate will go up. Remember that stuff from before? Your heart rate will go up because of the baroreceptors, chemoreceptors, and all that in the arch of the aorta. It's going to say, hey, your blood is acidic, you need to do something. So then that's going to make the heart rate go up, blood pressure go up, your blood's moving faster to the lungs, and then the lungs will do what? Cause you to breathe. And you're going to have to breathe in order to get it out of your body. Okay, next line. This is another important one. So again, these are factors that go with this. So this is the next one. So forming lactic acid, that's another reason why your blood would become acidic. Okay, so lactic acid, your blood will become acidic. So it says more BPG, the more oxygen is released. Okay, next slide. Again, this one is BPG levels when pH increases and when stimulated by certain hormones. Okay, so be aware of that. Fetal hemoglobin, same kind of story. Don't care too much about that one. So here's a slide with that. So fetal hemoglobin is able to carry more than the adult. Because remember, the fetus doesn't care. It's getting its blood cleaned up by mommy's breathing. Because remember, the fetus inside can't breathe. So it's okay with its function. All it's doing is getting all the waste to the mommy. So the mommy has to deal with it. The baby doesn't. Okay, next. Carbon dioxide. This slide is important. So this slide is important. Remember I kept saying aerobic? That's why. Even if you're just sitting still doing nothing, you're still aerobic in the sense that you're producing CO2. You're alive. You're producing CO2. 3 ways that CO2 is handled in the body. 1, it's converted to carbonic acid. I showed you carbonic acid a moment ago. It is worthwhile going back to that slide. And that is this one. So carbonic acid. And that breaks off into producing hydrogen ions and lowering your pH. So why is it important in that slide? It's important in this slide because that's how you buffer your blood. Okay. So the buffering of your blood is done by this process. So it's called the bicarbonate buffer system. So that number 1 translates to bicarbonate buffer system. Okay, number 2, CO2 is carried on hemoglobin. Okay. So that's number 2, carried on hemoglobin. And when we do that, when we have carbon dioxide stuck to hemoglobin, it is called carboaminohemoglobin. So carboaminohemoglobin. And then the last one there is dissolved in plasma. The sequence that we see here, 1, 2, and 3, is based upon its percentage. So the biggest way we handle carbon dioxide is by the bicarbonate buffer system. Next slide. It is now mentioned here. Notice it gives you the percentage. Okay. So a big chunk of your carbon dioxide is handled that way. So a big chunk of your carbon dioxide is handled that way. Okay, next. Okay, a moment ago I told you carbon dioxide is bound to hemoglobin. And I told you the percentages were in the sequence, so now we have 23%. And when you have carbon dioxide stuck to hemoglobin, as I said, it's called carboaminohemoglobin. And then I told you the lower percentage was dissolved in plasma. Next, we have a picture version of what we just talked about. So this is a picture version. I like that better than anything. So the picture version is important. Now look what it says here. In this line we have bicarbonate dissociates into hydrogen, H plus removed by the buffers, especially hemoglobin. Then in this case we have the bicarbonate ion moves out of red blood cell in exchange for Cl. Now the Cl down here is called the chloride shift. So let me go back to that line. So here's that slide a moment ago. It's dealing with the chloride shift. So this is how we ensure that we can do the buffering. We want to take those hydrogen ions that are by itself, those free hydrogen ions, and we want to make sure we couple it with chlorine. Now, to show that, instead of studying this slide, which I think is crappy, you want to actually see the picture version. So here's the picture version. This one is a very good slide. Let's follow this from beginning to end. Here we are in the lungs. So this is the lung here, alveoli. This is my blood capillary. Okay. What are we doing here? Oxygen is being picked up and it goes on to hemoglobin. That part makes easy sense. Then when we get to the tissues, what are we doing at the tissues over here? We're dumping the carbon dioxide off. Cells need it, so they're sucking it up like a sponge. O2 goes there. Okay, then we are doing what? Picking up the carbon dioxide. As I pick up carbon dioxide, and again, I'm talking about the major way. So as I pick up the carbon dioxide, two things will happen. One, carbon dioxide will stick to hemoglobin. That's your carboaminohemoglobin down here. But we're also going to have the bicarbonate buffer system, which I said most of it does. So here's our carbonic acid. It splits off to release the hydrogen ions, which would actually affect my acidity. And then we have our bicarbonate ion going off to neutralize the blood. To neutralize the blood's acidicness. And in doing so, we take chloride in. So we take chloride in. This helps buffer our blood a little bit. Then when we go here, what happens? We dump off the carbon dioxide. So carbon dioxide goes bye-bye. But we pick up the hydrogen. We dump off the chloride. And we pick up the bicarbonate ion again. And so we have our hydrogen now entailed. So this is going to help neutralize the acidity. So this added to the acidity, that neutralizes the acidity. Okay, next slide. So make sure you study this picture. Very, very important. So the Bohr effect, which would be this story here and related to this. Okay. And then you have the chloride shift. Draw a line. we now go to this slide. Control of respiration. Changes in blood flow, oxygen delivery, depth, and rate of respiration. Again, you see something similar to what the heart can do. The heart can only do two things. The heart can beat faster or beat stronger. The lungs can only do what? Breathe faster, breathe deeper. Same story. Okay, so we can either do blood flow changes, oxygen delivery changes, or affect the depth and rate of breathing. Next slide. Hey Nemish, I think you gave us this word a while back as a hint later on. That's right. Make sure you know this line especially. Coordination of lung perfusion and alveolar ventilation. That means that the lungs and the blood must flow evenly. You can't have too much blood coming into the lungs if the lungs are not doing their job. Okay. So you have to be able to have the heart and the lungs work in tandem. Okay. Any questions on that? Next slide. All right, now, what do I need to do when I have an oxygen demand? Well, I have several things I can do. Cardiac output. Hey, Nemish, that sounds familiar. Respiratory rate. That sounds familiar. Matter of fact, earlier you even talked about these two related to each other. Cardiac output, respiratory rate will increase under neural control. So the nervous system will tell the heart what to do, which we've already seen in the previous chapters. But at the same time, the brain will tell, the nervous system will tell the lungs what to do. Next slide. Now, having said that, brain story with the lungs. The pons and the medulla oblongata will play that role. You learned that in 2401. Let me refresh your memory on that part. The pons play primarily the role of rate and depth of breathing. So pons play the role of rate and depth of breathing, whereas medulla oblongata play the role of the initiation of breathing. Okay. So without the medulla oblongata, you would not breathe. Okay. Now, a form of control would be something like a dimmer switch, as an example. In a dimmer switch, you have a little click that you hear first. That's sort of like saying you just turned on that switch. And if you keep turning the dimmer switch, what happens to your light bulb? The light bulb gets brighter. Well, that's exactly what this is like. So the regulation of brightness, dim or bright, that would be the pons. The on-off switch would be the medulla oblongata. And of course, you can regulate on and off also as being what? A control mechanism. So that's what this is relating to. Of course, we're controlling who? The respiratory muscles that we've already seen. So not much information. This is just an overview. Next slide. This slide is important. Make sure you have these two groups down. It won't make sense until you see a picture version. So make sure you have those two down. And then this. This is next. So dorsal root group, ventral group. So dorsal group, ventral group. Okay, this slide is important. We already know about the passive breathing story. Okay, so this is something to keep in mind as well. So I would have so far that slide and this slide to keep in mind. Now this flow chart doesn't do much for me. If it helps you, that's fine. This slide is important. This slide is important. Again, all we're doing is controlling those muscles. So this is sort of like the brain center of a motor. Okay. Again, similar slide. Now this slide is very important. Now these are of the pons. So I already told you that pons plays what key role? The rate and depth. And what do you see mentioned right here? Rate and depth of breathing. So pons, rate, and depth. Now we have two main centers, the apneustic and the pneumotaxic. Okay. This slide is important. Okay. All we're doing here on this slide and the few others I showed you is explaining how we're going to control the muscles. Basically an on-off switch. Okay. Sort of like the way your blinkers work. Some people's blinkers blink really fast on their turn signals, and some blinkers run really slow. Well, that's what this is like. Okay. Again, slide that goes with that too. Now, to make sure we have pictures, here's your picture. Okay. So here's your pons, the pneumotaxic, the apneustic. I would study this picture above and beyond the slides I've mentioned so far. Okay. So I would really study this picture. You can see the stimulation effect and the inhibitory effect. So this is important. Now in the end, this picture, notice how it says muscles not shown, but this picture is actually going to do what? Stimulate this story. Okay. So that last picture is really affecting this story. So we're really saying what turns these muscles on, what sequence, how, all that. And of course, one of the nerves that you've learned before is your phrenic nerve. And that plays a role in your diaphragm. And of course, you now know diaphragm is important for breathing. Okay, now, I'm moving to this slide next, sudden infant death syndrome. In the past, we really didn't know much about it, but now we know that it's really more of an issue with the brain. So we know that somehow something caused the centers in the brain to basically shut off. And that's why you have the sudden infant death syndrome. Okay. Next one. Reflexes. Now this is to let you know that there's many reasons for how our respiration rate would change. We already mentioned in my story with the aorta earlier, as a matter of fact it's mentioned right here again, that we have chemoreceptors, baroreceptors. Well, that's true not only for the blood, but also for the lungs. So chemoreceptors, baroreceptors, I call it proprio, the book is calling it stretch, same thing. So proprioreceptors, baroreceptors, chemoreceptors will play a role in the respiratory reflex. Okay? Having a bowel movement will affect your breathing. When you win the lotto and you have an emotional outburst, that's going to affect your breathing. Okay? Pain. You step on a nail, that's going to affect your breathing. You have a fever, that's going to affect your breathing. So this slide right here is to let you know that how we have a difference in our stimulus. These are all different things that can act as a stimulus for our reflex. Okay. The author now goes into each of them. So we now have our chemoreceptors involved. A key one, of course, is your vagus nerve. So your vagus nerve plays a key one there. Okay. So vagus. Now we have glossopharyngeal for the carotid. I would definitely keep this slide in mind because this is a major slide for somebody. So glossopharyngeal from the carotid. The vagus nerve from the aortic. Okay. So this is coming from the aorta. That's coming from the carotid. Okay. So again, our sensors in essence, our sensors. Next slide. Here's what our sensors will do for us. Notice it says pH of cerebrospinal fluid. Because remember, we cannot screw up the brain cerebrospinal fluid. We cannot have too much CO2 buildup in the brain. Okay. It's going to screw up with the brain. So you want to make sure that the pH of your brain fluid and the CO2 levels of